Welcome to Behavioral Health Today, a podcast by Triad Behavioral Health, where we cover trending topics in behavioral and mental health. This podcast is designed to share unique and relevant topics occurring within the world, our communities, and bring them a mental health perspective. Due to the sensitive nature of today's topic, discretion is advised for younger listeners.
I'm your host, Dr. Graham Taylor, and I am joined today by Natalie Liberman, licensed marriage and family therapist, licensed clinical social worker. Natalie has a breadth of information. She's been a faculty at the Jerry Grossman seminars since 2012 and is an adjunct faculty at the Pepperdine University Graduate School of Education and Psychology since 2015. Natalie's worked in various clinical settings, overseeing services provided to the individuals diagnosed with persistent mental illnesses, elderly and frail clients contending with chronic medical illnesses, and those struggling with substance abuse. In her private practice, Natalie works with an array of clients dealing with substance abuse, trauma, depression, anxiety, relationship issues, career and life transitions, sexual problems, social anxiety disorders, communication issues, self-esteem, and general quality of life issues. Natalie, it's great to have you with us. Welcome to Behavioral Health Today.
Thank you, Graham. It's great to be back.
Nice to have you here. You know, our topic for today is actually a very challenging but extremely important topic. It is the 10th leading cause of death in the United States. Roughly this year, 50,000 people will die of this issue. An estimated 1.4 million will attempt this in this year alone. And what we're talking about is a topic of suicide. And my goal today in this podcast, and really want to tap into your expertise and understanding of this issue, is to get a deeper understanding of this personal and societal issue, and really to gain a greater appreciation for what an individual contemplating suicide is really dealing with. And I'd also like to recognize and identify too, that these things that go into suicide, that there are a number of things that we can do to address and help with this issue as well. If I could kind of get us started and kind of prime this, when we typically think about suicide or we hear about suicide, what have you noticed some of the common thoughts or even misperceptions are about this idea of suicide?
One of the greatest misperceptions that I've encountered in clinical setting and academic setting is that people are still have a misnotion that when you bring up the content or the concept of suicide, generally somehow you're able to plant an idea and something that inevitably you provide people an idea, something that they haven't thought of. And now you go around feeling responsible for somebody's attempt or perhaps completion of suicide. So that's one of the big issues, is that as clinicians, we have to be very, very skilled of how to open up a dialogue because of such a tremendous stigma. And our own issues, whether we're aware of them or not, are bringing those insecurities about how do we begin the dialogue with somebody that is considering taking the most ultimate action. The second prevailing misnomer that I've encountered is that general public tends to think that people that die by suicide are very selfish, that this is something that they do in terms of punishing other people. So I think we have to really be mindful of how we speak about it. The terminology has been updated. We no longer are encouraged to ever use the word committed suicide, because by saying committing suicide, we are criminalizing the act. So the most relevant language now is that as clinicians, we have to watch and we have to say completed suicide, or better yet, died by suicide.
Yeah, that's a really great way to start us out. I think there is such a fear to even name it or bring it up, both for the person contemplating it and for those around them that might suspect that there could be something going on. And the idea, if I talk about it, I'm going to actually set it in motion. I mean, like you said, I'll be responsible. I'd like to talk a little bit more later in our time today about ways that we can bring this up that we know can be helpful. The other part you said too is that this is something that someone does in a selfish way. I've heard multiple people say, well, that's just selfish, or it's just seeking attention, or it's, other reasons that tend to minimize the seriousness of this. So we're starting out, I think, in a really good way. When we talk about suicide, we know that there are are underlying factors that can typically go into one getting to a place of wanting to follow through with the suicidal ideations. And we sometimes look at, well, are there risk factors? Are there warning signs? Speak to those two a little bit with us, if you would. Warning signs and risk factors. And is there a difference even between these two?
There is a tremendous difference. I've only not seen it in literature, but I've also seen it in practice. I've seen it in clinical settings times and time again. Yeah. We all have heard of instances where somebody had been able to successfully complete suicide, and yet most of us are really taken by surprise. Mm-hmm. So the difference is really significant in a sense that if you have a risk factor, it means that you have a condition, whether it's hereditary or perhaps it's your life circumstances, that is putting you at a higher risk. That just because you have a predisposition, so to speak, it doesn't mean that this is something that you will have to grapple with necessarily. Mm-hmm. So what are the risk factors, for example? Being a male is a risk factor. Yeah. We know, statistically speaking, 3 times as many males will complete suicide. Why? Because males will choose typically more lethal means.
Yes.
For example, we still have a lot of work to do in terms of frequency of it. To put some context in the numbers that you said, 1 attempt is going to be made every 26 seconds. So when you put it in the context of how prevalent this is, I think as clinicians, we need to be really aware what are the risk factors. If somebody is using substances, that is a risk factor and a warning sign. So some of them will cross over, but risk factor essentially, every single client that you encounter, especially if you don't have history, if you're building rapport, you have to be on the lookout. What are the possibility that this client had either had passive suicidal ideation or active or acute suicidal ideation? And if it gets to the point of acutity, meaning that it's really present in the moment, people are actively talking about it, people are looking for means and have access to means, or perhaps they are leaving notes, or if they've had past suicidal attempts, those are all already now no longer warning signs, but now these are risk factors.
Yeah, those are good. It's interesting just to recognize that these are things that we can begin to identify, things like age, gender. Are they substance abusing or using more, relying upon that? Situational factors in their life. Are there some stressors in their life that heighten the risk? Is it work-related issues, jobs being lost, changes? We're going through a really challenging time in our society right now. Work-related issues, identity issues, social relationships, isolation. Those are really all risk factors, aren't they?
Yes, they are.
Yeah.
And also people don't recognize the risk factors of physical hereditary, because virtually every single person that completes suicide is going to communicate that they're not looking to end their life, they're looking to end the pain.
That's right. It's interesting you should say that. When I've worked with a small handful of survivors who fortunately did not complete their suicide attempt, and to the person, they said, Graham, it's not that I wanted to die. I just wanted the pain to stop. And that's the part that we oftentimes really miss. This isn't an overnight decision. This is something that builds typically over time. It's not just an acting out or a tantrum or attention-seeking thing for those that are really seriously contemplating. And instead, it's those that reach a place of despair and hopelessness and see no way out from this pain that is just simply, like you're suggesting here, unrelenting. In fact, you could even say it's maybe a coping strategy. It's the last coping strategy they could possibly attempt to try and minimize what is a deep, psychically felt, unrelenting, despair-based pain. It just gets so dark and their lives become kind of myopic. It becomes very, very small and painful, doesn't it?
Very true.
Yeah.
Very, very true. I wanted to mention this. I don't know how many people out there are aware of this. We all have studied about moral development and Lawrence Kohlberg.
Yes.
Are you aware that he actually completed suicide?
I did not know that.
He actually was studying in Belize. He was working there. And while swimming in Belize, he contracted a parasitic infection.
Is that right?
And the pain was so severe that he had left a note in the car and he drowned himself.
Oh, I did not know that. Yeah. Well, we're talking also about, those are risk factors, aren't they? But there are also warning signs. And the important piece about this is that there are things, in hindsight, that when people are asked, they go, well, this is uncertain. I didn't see these things. But as we start to talk about what some of the warning signs are, very, very frequently people will say, you know what, actually they were doing that, but I did not know that that was a sign. I didn't know that was something that I should be paying attention to. But the good news is these are things that we can know ourselves. So if anybody around us, a loved one, a friend, colleague, coworker, whoever it may be, begins to evidence some of these signs, we can intervene early and just begin to get a conversation. And sometimes a conversation, which we're afraid to do sometimes, can actually be started by some of these things. But before we get into the conversation part of it, let's talk about some of the warning signs and what you know to be some of the early identifiers of somebody who seems to be kind of inching towards suicide being a way out. What are the warning signs?
I'd like to give you a little bit of an analogy to perhaps bring you home, because
Good.
like you said, the warning signs are always there. The problem is that we tend to not pay attention to them.
Right.
So there is an old Cherokee proverb that says, if you hear the whispers, you won't hear the scream.
Yeah.
So as clinicians, we got to recognize what the whispers are. And the whispers of warning signs of suicide.
Yes.
Increased use of substances.
Yes.
Having no sense of purpose in life.
Yeah.
Increased sense of anxiety when it becomes disabling.
Yeah.
Feeling trapped. Feeling a sense of hopelessness that things will not get better.
Yeah.
Withdrawing.
Yes.
Anger or reckless behavior. Sudden mood changes. It is typically not a single event. It is just that straw that broke the camel's back.
That's right.
So when people have pre-existing mental disorders, any life stressors that taking you unprepared and overwhelms your ability to cope, that seems to be the catalyst that puts people in emotion, because once again, the goal is to not end life. The goal is to end suffering and pain.
That's really good. Why do you think, this may be a little bit more philosophical, maybe existential question, but why do you think it's the 10th leading cause of death in the United States? This is something that we can prevent. But why is it the 10th leading cause of death, do you believe? Any thoughts?
Yeah, I have thoughts. And I can tell you that just a few years ago, it was 11th leading cause in the United States. So it's basically letting me know that the shift is happening. Yeah. And in my opinion, the shift is happening is because we don't have awareness of it. Yeah. We are isolated. We are more connected than ever. Instead of figuring out who they are and what they want to pursue, they're not looking at their own factors to address anything, and they're living their lives from the other side of the screen, and it's leaving people to be more isolated. We have more stressors now than we ever had before. Yeah. We work more. We don't take care of our health. We are stressed out more. There are more financial pressures. There are more responsibilities of taking care of our aging generation. We have children that have their own demands with all of these explosion of technology. People are feeling overwhelmed. And I believe that the reason why the 10th leading cause, especially preventable, is because people are suffering in pain and they're suffering silently.
That's right. That's right. What a great point you're emphasizing there, that we are able to be more connected with each other, but there's a greater sense of isolation. And you think about that's almost a paradox. It's hard to kind of hold, because those would normally go together. If I'm more connected, I feel, less isolated, but that's not the case. There's greater anonymity on the other side of the screen. There's a lot of comparison, the FOMO, fear of missing out, all these other things. And I think on top of that, we've watched the family breakdown. We've watched the societal breakdown. We've watched those organizations typically that we have in life and not be as attended, whether it's one's synagogue or temple or church or community centers, whether it's cutbacks or they're just not engaged quite the same way. That structure that gives us identity, that gives us connectedness, that gives us, a sense of understanding of ourselves and others, just isn't there quite in the same way. So people, like you said, are going through a life now that is very challenging in very unique ways, but without the support, the relationships underneath them. And I think that really, really, truly does increase the susceptibility. So maybe that leads into my next question here for you. What is the person that's contemplating suicide really experiencing on the inside? What are they feeling? What are they thinking? What's going on for them, do you find?
A lot of ambivalency. They're looking for any sign to hold on to this, give me a reason to live.
That's right.
And that ambivalency is so permeating that oftentimes when somebody, like I said before, on the other side of engagement, recognizing that whisper that they're in pain and they're searching for the reason to stay on the side of living, that in itself tends to be therapeutic because you open up a gate and people are able to start discussing a taboo subject because we do live in a culture of silence.
Yeah. Yeah. I think that's really good. I think as you're talking about those experiences of one's internal world, and it is hidden, it's in whispers. I love that saying. It is in whispers. And oftentimes they don't even know themselves that they're going down this path. This is just a path that they're finding themselves in. It's not like they're saying, I'm going down the suicidal path today, or that these are suicidal ideations. They may not even recognize themselves that these warning signs that they're exhibiting are really something that they themselves are progressing in and becoming more vulnerable to follow through on. And to be able to not just talk about the risk factors, but these warning signs, isolation, the idea of not being as motivated, turning to more substances or more destructive ways for managing or coping, sleeping more, sleeping less, becoming, moody, becoming less tolerant, more easily irritated, angered, more depressed. Back in the early 90s, I was on a committee, the Public Education Committee for the Psychological Association here in Hawaii that I belong to. And we put together through the American Psychological Association, the Warning Signs program. And this was just before Columbine happened, the Columbine shootings. And like you said earlier, when we look back on the set of events that precipitated the set of shootings, we see all kinds of warning signs sticking out, red flags all over the place, but we don't oftentimes know what to look for. And if we could become aware of the risk factors, these were teenagers, we could become aware of the warning signs, they were all there. And we could begin to recognize those the same way that we might recognize that, a cold has a runny nose, sneezing, scratchy throat, and coughing. That's a cold. Those are the warning signs. If we can become as aware of and as intuitive around signs for suicide, I think we can intervene early. So if I'm watching these warning signs and I'm seeing these emerge in somebody, and I know that there's a risk factors, I'm kind of recognizing some of the risk factors there, where there's age, gender, ethnicity. How might I see somebody who's beginning to withdraw? Or I'm noticing him having a couple more drinks than usual. Or he's beginning to be a little bit more aggressive. He had a little more road rage than I remember him having or her having. How might I start a conversation with somebody like this? What would I do? What would I say? Because I'm really afraid that I'm going to tip them off and be the cause of putting something suicidally in motion for them.
If you know that the person is not currently in acute crisis, I think it would be very helpful to open up a dialogue with open-ended conversations about, I can begin to notice that something is going on for you. In our sessions, I'm noticing that your body language is changing, and I'm noticing that you're not quite the same as you are. Have you noticed that? Does that resonate, what I'm saying? And that typically allows people to not shut down. Because once again, there is a lot of judgment about, should I even have these thoughts?
Yes.
And we talked about the fact that it's rarely a very sudden occurrence. We have to know how to recognize these subtle signs where people are typically will be showing us, and we just happen to miss it. Because think about anger. You're bringing up a really, really great point. And it's what Freud that said, that anger is depression turned inward.
That's right. And
we typically don't recognize males have a completely different presentation of depression as females do. Yes. We live in a culture where men don't talk about feelings. So the idea is for us to recognize and open up that dialogue for people to feel accepted for who they are, for whatever perceived flaws that they've had. And a lot of times those that interject that have been given to us, and they're unconscious. And we have these dialogues in our head that are stemming, and people do not know how to talk, how to open up. So the skill that we as mental health providers have is that we are artists in a way of opening people up, and they're able to talk.
That's really good. I think one of the things that if I bring about it or I name it, then it's going to happen. What we know is that folks that are going down this path so want to be connected to, so want someone to reach out and just understand the situation that they're in, not change it, but understand where they're in and kind of join them in it. It's almost like when we talk about youth, if I talk about sex, with my teenager, they're going to go out and have sex. Or if I talk about drug use, they're going to go out and, start using drugs. Or if I talk about suicide, they're going to go down that path and I'm going to be responsible. The opposite is true. We know that if we can bring these things to a conversation level, they'll be less likely to be acted out, because they're being acted out usually out of despair, out of concern. So the idea that we can just gently notice, you're talking about as a clinician, maybe for the layperson that has a coworker that says, hey, you're not attending the social meetings that we typically have, each month, the same way you did in the past. And I noticed you're kind of withdrawn and kind of quiet. You didn't return my text the other day. You doing okay? Or I noticed when we went out and had a little happy hour the other night that you kind of had a couple extra drinks. And I know there's a lot of stress at work. And like you said, open-ended questions that just get to be observational type questions that gets a dialogue going. And most people that are going down that suicidal path really want to talk, because the whispers are there, but they may not even recognize themselves that they're going down that path. So it's scary. Do you see any particular challenges for youth in this kind of generational time for us that might put them at particular risk?
I actually do. And I have to tell you, not too long ago, the statistics actually changed.
Yes.
We've always known that elderly and teenagers were at the highest risk. But if you look at statistics, we've actually made a lot of improvements because we've been paying attention to the risk factors of age. However, currently, people that, statistically speaking, have been able to be successful in completing suicide, these are the people that are middle age.
That's right.
So think about how many people currently are sitting with this overwhelming sense of anxiety and doubt. What does my world look like? And they're looking for anything to have this self-fulfilling prophecy is, this pain is unbearable. And just like you've mentioned, the fact that we are missing an opportunity to begin conversating with people and just really getting down to, you are being heard. And a lot of times it's okay just to say, I am just here to listen, and it sucks, and let's go through this together, and let me know how I can support you.
Yeah, I really like that. I think sometimes too, and I've come into conversations and I've said, I'm going to be really clumsy, as I try and ask this question, or I'm going to seem uncoordinated and probably trip all over my words, but my heart's in the right place. Would you bear with me as I try and ask some questions here, or particularly with youth? We know that 7%, this kills me, 7% of youth in grades 9 to 12 reported that they made at least one suicide attempt in the last 12 months. That's pretty staggering. 7% of the youth in grades 9 to 12 have made at least one attempt. So this idea that, we can begin to talk about these things, absolutely we can. There's something we can do about this. And if we're scared to do it, name the fear you have. Hey, I want to come and talk to you about this, but I'm scared to say the wrong things, but I care about you. And if you could bear with me, can I ask just a couple of questions, or just share with you a couple of observations that I've got, and just get the conversation going. Most people are so welcoming of someone, like you said, just seeing them, someone working to try and understand them. So there's some grace that usually gets involved in those conversations that people are very, very appreciated in that.
They do. And like you said, adolescence is a very, very peculiar time in our development.
Yes.
We have a very rigid thinking. Everything has to be instantaneous. We don't have an ability to delay any gratification. Everything is black and white, a lot of cognitive distortions. And this is a time when especially parents oftentimes and clinicians are lacking the skills to open up a dialogue, because for some reason, when we think that we cannot talk about some of the unconventional topics, perhaps the topics that my parents and your parents did not talk about,
yes,
we're basically allow them. We're giving them a message that there are no taboo topics.
Yeah. There are a number of things that are taboo or difficult to talk about, or generationally just not very practiced. And we add into what we talked about earlier, because of electronics and, all the social medias and things online, we're not as connected. So we're not as connected to begin with. And now we have to have these very important conversations, and we're not very practiced with them. I work with some parents sometimes with their teens, and they're having to address things with their teenagers, but they haven't done the foundation laying relational stuff in their earlier elementary school years, ages, 0, let's say, to 10. They haven't done much relationship building. And so now they're having to have some hard conversations when they're seeing some of these warning signs, or there's some difficult signs, and it's very, very challenging. But the answer truly is just getting curious. Even if we say, I don't know how to talk about this. I'm a little clumsy at it, but if you bear with me, I'd love to hear what you're going through. That's all we need to do to get the ball rolling, isn't it?
Yeah, because you will give him permission to be seen and to be heard.
Yep.
And we also give him permission that we're not perfect. I'm not going to land well with whatever message I'm giving you. And it's not about putting it in the package and giving it to you in the most pretty fashion. It's okay to mess up. It's okay to not be as eloquent.
That's right. What stokes my thoughts is you don't have to fix it. Nothing has to be fixed or rescued. It just has to be joined and understood. That's it. If you do that, that's the fix, isn't it?
The fix is to being seen and to be heard.
That's right. That's right. We do that. People feel less isolated. They can address these things that are a challenge, and the despair begins to lift in time. Sometimes we also find, too, that some people are in such despair that sometimes some psychotropic medications, a kind of an antidepressant or anti-anxiety medication, can be a helpful adjunct, or bringing other relationships in can be supportive in a way, and engaging people in things so the isolation is reduced. But there are also other things that we can do to support people. There are agencies out there, suicide and crisis lines. I've got a couple of things that come to my mind. Are there any thoughts that you have in terms of good programs that you might refer people to or have them check out?
Well, we have to be also mindful of LGBT community as a whole, as well as our adolescents, because adolescence is a time when we're trying to discover ourselves. And sexuality oftentimes, especially when you're not being accepted in your family of origin, tends to be a big trigger.
Yes.
And the idea is, if I'm not accepted, let me just go out of the way. So the two specific resources that I find very helpful is the Trevor Project
very good.
and the Trans Lifeline. This is specifically for individuals that are transgender. For teenagers, adolescents, they are not really oftentimes are able to talk, and oftentimes there are people present around, so perhaps it's not as safe to open up in dialogue. We do have a crisis text line where individuals are able to text the word home to 741-741, and they're able to get somebody on the other end of the phone, because we know generationally teenagers are more comfortable with texting. Local communities also. In LA County, there is a website, and you're able to find out based on your address where you can get resources as well. And there are really great resources. One of them is American Association of Suicidology.org that has a lot of really wonderful information. There is a Foundation of Suicide Prevention, and there is a specific agency that is dedicated for dealing with youth, and it's National Center of Prevention of Youth Suicide.
Very good. Very good. Yeah, those are terrific. I'd add in there a couple more. There's an American Foundation for Suicide Prevention, and also the Suicide Prevention Resources for Survivors of Suicide Loss. So these are all accessible resources that we have. Again, this is an avoidable issue. This is something that we can be addressing. We can look at the warning signs, understand the risk factors, really understand the person going through it. And there are some ways that we can step in early to help prevent this and to really reduce the numbers that are occurring out there.
My experience has also been is that when somebody is contemplating suicide or perhaps hasn't been successful in completing one, oftentimes they're looking for support and credence from somebody who's walked the walk, so to speak.
Yes.
So for those individuals that have made attempts, and we know that up to 80% of completed suicides are done with the person attempted before.
Yes.
There is a wonderful program that is spearheaded by Kevin Caruso. It's suicide.org. He's a survivor.
Oh, very
and
good.
he does an incredible advocacy. He's very outspoken. He is telling his personal life story, and he's providing a lot of resources for people.
That's terrific. I love that idea. Sometimes it's helpful when, that old saying, it takes one to know one, and to have somebody really understand your process, and someone who's kind of been there and gone through it is on the other side to provide that hope. There is hope around this.
Yes.
This is, not to sound cliche-ish, but people refer to this being a permanent solution to a temporary life set of circumstances that are going on. And there are ways to get through these things and opportunities to have people join you in getting through these things without having to take that step. So this is ideally a podcast of hope. This is a podcast of understanding around the suicidality and what it means, what people are going through, to talk about the importance of addressing it with courage and to understand what's going on and really at some depth and some ways that we can prevent this from occurring. It'd be nice to put this at a cause of death being 11, 12, way down the line, wouldn't it? It'd be nice to change that.
Absolutely. One more thing I want to point out. There are quite a few individuals out there that have been personally touched by somebody that had died by suicide.
Yes.
So I think that we also have a lot of work to do with those individuals, and the term had been coined, post-intervention.
Yes.
Not intervention, but post-intervention. And I think one of the biggest things what we need to address is they carry tremendous guilt.
That's right.
Guilt over not able to recognize, not able to perhaps identify or make the difference.
Yeah,
and I love that somebody stated that guilt is what we feel when we place our anger where it doesn't belong on ourselves.
Mm-hmm. Yeah, really misplaced blame, isn't it?
Yeah.
Well, Natalie, it's always great to be with you. This is a challenging and yet important topic, the way we started out today. But I appreciate the expertise and the insight and the information you brought us today. It's always great to be with you. Thank you for joining us.
Thank you for having me.
Folks, thanks so much for listening to Behavioral Health Today, and we look forward to being with you next time.
Behavioral Health Today is a podcast part of the Triad Behavioral Health Network, all rights reserved.